Well, welcome everyone. Thanks for joining us this morning. We've been getting a lot of questions about the updated COVID booster and about flu season, which is upon us quite soon. So we have a couple of guests with us this morning who will help to answer some of these questions. We have Dr. Hannah Emle, who's Assistant Professor of Internal Medicine in the Division of Infectious Diseases at U of U Health. And we have Dr. Kensey Graves, who is Associate Professor of Internal Medicine and Chief Medical Officer for Inpatient Health. So thank you both for joining us this morning. Dr. Emle, I'm going to start with you. So help us understand a little bit about this new COVID booster. If you've already been boosted, for many people have already been boosted twice, do we still need to get this new booster?
Good question. So what the vaccine policy has been so far has been a primary series that provides a lot of immunity against COVID-19, and then follow-up boosters, which have been serially authorized by the FDA and then used. And these have all been targeted against the original strain of SARS-CoV-2. So I call that the ancestral strain of SARS-CoV-2. However, as everyone has now observed, we've had successive waves of different variants of SARS-CoV-2 that have sort of swept across our globe. And these include variants that have substantial immune escape, meaning they've changed the structure of their spike protein. And so vaccines target these less well. Now they do a fantastic job, particularly against severe disease and mortality, even only targeted at the ancestral strain. However, 2 years into this, the idea was to create boosters that were specific to the circulating variants, not to the first variant that we've seen. And so that's where this bivalent booster came from. Moderna and Pfizer both have authorized bivalent boosters, and each of them have 2 antigens in these vaccines. One of them targeted against the ancestral strain. So same kind of formulation, same target as the previous boosters and as the primary series. And then the other target is against the most recently circulating variants, BA5 and BA4, which have the same spike protein. So this targets both of those things. And the idea being, this gives a more specific response, specific antibody response against the most recent circulating boosters, as opposed to what we originally saw. These are now authorized as of a few weeks ago. And the hope is that they provide more specific protection while maintaining, good protection against the ancestral strain and more specific protection against the most recent strains. Now, people who got the previous boosters are quite well protected, as I mentioned before, specifically against the more severe disease outcomes. However, we've noticed that immunity against just any kind of SARS-CoV-2 infection tends to wane after a few months. And so this is supposed to be a new prime of your immune system and a new prime against new variants for your immune system if you have not already seen these variants.
So it works a little bit better against the BA5 that we're seeing right now, which is the most common strain.
That's the goal, yes.
Okay. Now, what is the waiting period? I know it used to be about 6 months between shots, and this one is shorter. So can you tell us, if you got a booster in the spring, when can you get this new booster? And also, is there optimal timing as we head into the holiday season? Should you hold off so you're boosted, right around Thanksgiving or that sort of thing?
I've got to say that one of the most confusing things has been when you're supposed to get vaccinated. And all of these intervals have been very different. So the time between the primary series, the time between the first booster, the time between et cetera, has all been different and very difficult to navigate, to the extent that I look it up every time, to be honest. These new bivalent boosters are authorized to be given at least 2 months, so starting 2 months or later, after your most recent dose of the primary series, or your most recent booster dose. So there is now no longer a recommendation from the CDC to do a bunch of boosters in between your primary series and this bivalent booster. The recommendation is now, regardless of how many boosters you got between primary series and bivalent booster, the recommendation is now bivalent booster at least 2 months after the last dose of your primary series or the most recent bivalent booster that you've received. As you can see, it's a little bit difficult. The other consideration that was recommended by the CDC, now we are 3 years into the pandemic and still have incrementally increasing knowledge about what is an optimal vaccine strategy. And so the other thing was that it's been noticed that spacing out your vaccine doses or spacing out the time between infection and vaccine doses improves the long-term antibody responses. And so what is a consideration in the CDC recommendations is if you've had a recent COVID-19 infection, that you could consider waiting 3 months from the COVID-19 infection to the bivalent booster receipt. And the idea being, you've got a lot of immune priming from your infection, you get a lot of immune priming from your most recent vaccine dose, so wait some time before getting the bivalent booster. Now that's a general recommendation, but if you have something big coming up, for example, something where you might be likely to be exposed, or you're immune compromised, you may want to do that booster sooner than the 3-month window between most recent COVID infection.
Okay, and then so I guess the key number here is 2 months.
2 months.
2 months, and then if you have something big coming up, and then in terms of targeting like holidays coming up, is there a good time, or should you just get it now? Should you wait until October?
So we don't know, what the long-term waning looks like. Does it wane in 6 months? Does it wane in a year? We suspect that after, quite a lot of data looking at all of our past boosters, we suspect a very good, robust response against SARS-CoV-2 acquisition for at least 4 to 6 months. So now would be fine, and closer to the holidays would be fine too. I would say that it typically takes at least some time between vaccination and having full protective immunity. And so I would reserve at least 10 days between vaccination and a potentially high-risk exposure period.
Okay, and I have a couple more questions for you. Does it matter Moderna or Pfizer? Can you mix and match? I've heard sometimes it's maybe better to mix.
You can mix and match, which has been a change in the recommendations. There are good data that mixing matching in some cases does improve your neutralizing response. I would say there's not a lot of data for every single permutation of mixing and matching out there. So in general, I still recommend get the one that's most convenient and the one that's most available to you.
Okay, and we have a question from KSL. We're hearing Moderna is not as available as Pfizer. Do we have enough of this new booster available in Utah?
I don't know the answer to that question. I do know that there has been limited supply, at least in the rollout, but as far as I know, it is expected to be fully available, but it may be not so available here at the beginning. Okay,
that's maybe a question we could direct to the Department of Health. And then, where are we with the pandemic? A lot of people feel like and act like the pandemic is over. Is it over? Do we need to be concerned?
That's a very complicated question. Because obviously it's very clear that it's not that people aren't getting COVID anymore. We still have, give or take, depending on the day, 70,000 cases in a day. And 500 deaths in a day. I mean, and this is sort of rough numbers. So by no means is this done. That said, a lot of policy decisions and choices that we as a population have made have sort of really transitioned this from being a large-scale public health response to a response that hopefully is more sustainable and kind of is termed the endemic model. The fact that we don't think that this virus is going to go away. We think there will be ongoing, probably high numbers of cases nationally, and trying to emphasize the tools that each person can use, so more on a personal level of protection than a population level of protection. We still know that vaccination is absolutely helpful. Over the course of the pandemic, we, particularly since the Omicron variant kind of hit in the winter of 2021, we've seen that the severity of disease has gone down, and there's multiple reasons for that. We think some of that is inherent to the virus. The virus causes less severe disease. We also know that a lot of that is inherent to a lot of people having been vaccinated or had an infection, so immunizing events. And we know that that has been helpful in preventing severe disease. Even with immunization And even with people having had COVID-19, the infection, we know that patients who are vaccinated, particularly with full primary series and prior to this most recent bivalent booster authorization with multiple monovalent boosters, have a lower risk of death than people who are unvaccinated or people who even had received the primary series or one booster. So vaccination is still probably our single most important and most helpful tool for providing protection against severe COVID-19.
Okay, and I have two more quick questions for you, and then we're going to shift over to flu and talk to Dr. Graves. But are we seeing anything in the modeling that indicate we're going to have another wave of COVID coming in the fall like we've seen? And also another quick question about the booster. How long after you get it will it protect you?
So with regard to new variants, my latest information is that we are likely to have another wave this fall. It looks like, looking at the variants are sort of growing in popularity. They're both two subvariants of Omicron, so subvariants of strains that sort of the nation has seen before. But similar to what happened with Omicron relative to previous variants, what we've seen is a trend of more immune escape and higher transmissibility with successive variants. So from Delta to Omicron, more transmissibility and more immune escape, meaning people who've been vaccinated, people who've had previous infection were more likely to still get subsequent COVID-19. So I do suspect that we will have another wave. I suspect it will be characterized by some immune escape. And that's really the goal of having an updated bivalent booster that is strain specific to try and cut down on some of that immune escape.
And tell us again what immune escape means.
Immune escape meaning that the virus is structurally distinct enough that it can evade immune responses, those immune responses coming from vaccine or coming from previous infection.
Okay. And then the other question was, after you get the new booster, how long roughly do we feel we have protection?
Can I clarify? Between receipt of the booster and when you have kind of full protection of the booster, or between receipt of the booster and how long you'll be protected, like in number of months?
Between when you get the booster, how many months after can you feel like you have protection against COVID, getting COVID?
Yeah, so we don't know. And a lot of that depends on, some of that is person specific. So if you have a weakened immune system, if you are immunocompromised, we know that any kind of vaccination event is less effective than if you're not immunocompromised. So there's a person specific reason why you may not have as good of a response. There's also variant and virus specific reasons. So if we, subsequent to the bivalent boosters, have a surprise variant that's very different than what the vaccine's targeted, then that would be another reason why, again, a manifestation of immune escape, that would be another good reason why those bivalent boosters wouldn't protect for as long. What we had seen from the previous monovalent boosters was quite good protection against symptomatic infection for about 4 to 6 months, very good protection for severe disease for longer than that. So that's what we hope from these current boosters, at minimum, and hopefully much longer if they are very specific to the upcoming variants.
Okay, Dr. Graves, I'm going to turn it over to you now. We're also hearing, based on what we're seeing in other countries where they're already starting to see flu, that it might be a bad year for flu. Can you tell us a little bit more about that?
Yeah, so I'll start by just giving some information about other countries and their experience with the flu. So it's important to remember that Australia is in the southern hemisphere, meaning that their seasons are opposite. So they just finished winter. And it's also important to note that the last 2 flu seasons are really atypical. And the reason is we were really deep in COVID-19, and as a society, taking a lot of precautions to prevent that. So the things that prevent COVID also present flu transmission. And so broadly speaking, for the last 2 flu seasons, 2020 and 2021 and 21 and 22, we really haven't had flu outbreaks. So we are pretty naive to the flu, looking back a few years. So Australia, as I mentioned, just finished their flu season. In 2021, they had only a handful of hospital admissions and 0 deaths. For this past flu season in Australia, they had 1,700 admissions and about 300 deaths. So for them, that's a 5-fold increase in severity and deaths from influenza. That is what makes us here in the US a little concerned about how severe this flu season could be.
Okay, and tell us about flu vaccine. So I'm worried people are going to get a little vaccine fatigue here, but we do need to get our flu vaccine as we always have. So how important is that vaccine, and what is good timing for getting your flu vaccine? Is it okay to get it now? Should we wait a little longer?
Yeah, so I'll address that and then actually comment on a question a moment ago. And so the good news about flu vaccination is it's pretty predictable year to year. So unlike COVID, where we're learning as we go, we kind of know what to do with the flu. Now, it's important to recognize that the flu vaccines that we get change from year to year based on what virus is circulating. So what we get in 2022 is a little different than 2021 than 2020. But that said, the timing is almost always exactly the same. And so it's recommended that we get a flu vaccine in September or October with a deadline generally of Halloween, October 31st. And the reason for that is that the flu season really starts in October and continues on often through March. We want the flu vaccine to be on and present in the body long enough to give someone immunity through that entire season. And so that's why we have the timing that we have. To touch on a question a moment ago, and that's availability of vaccines. So as a reminder, vaccines.gov was the tool we used in the COVID pandemic to find vaccines. That still works, both for the bivalent booster that Dr. Imlay discussed and for flu vaccines. I'll tell you, I just did a search. There are vaccines available across the valley. I booked mine, got both on Saturday, and it was wide open. So there's a lot of availability of vaccine out there. Just one more comment for those who are immunocompromised, pregnant, or over 65, the recommended vaccines might be a little different. Generally, the guideline is to get one and get the easiest one, although it should be attenuated for those that are immunocompromised. And then there are some specific 4-component vaccines for those 65 and up.
Can you get your COVID booster and your flu vaccine at the same time?
Yes, you can. And one of my favorite quotes came from, I think, Ashish Jha over the weekend, and he said, God gave us 2 arms, one for each vaccine. So I actually got mine at the same time this weekend. You will have 2 sore arms and maybe a bit of fatigue, but if you have limited time, getting them at the same time is totally fine.
Now, if you've been a person who maybe you had some side effects in the past from the COVID vaccine, it's not going to make it any worse, or is it?
Yeah, no, that's a really good question. And Dr. Imlay can add too, is I think that the bivalent COVID vaccine could affect us all a little bit differently. And so I think some people could get a headache, some people could get really fatigued, some people may not have any response at all. I don't think it's unreasonable to separate them if you've had a severe response in the past, but the important thing is that you do get both, because it's important to remember that, like the COVID vaccine, the flu vaccine's most important thing, it does 3 things: reduce the incidence of getting the flu, reduce the mortality from influenza, and reduce your ICU likelihood of admission. Those are all really, really important to maintaining health. So bottom line, get them. If you separate them, that's okay. If you get them together, that's okay. Just get them.
Okay, now I want to talk a little bit about people who are immunocompromised, and I also want to talk about pregnant women for both vaccines.
Okay.
So I'll start with you, Dr. Graves. How important is it to get the flu vaccine if you are pregnant or immunocompromised, or if you're an older adult?
Yeah, great question. So I think I'm going to tease them apart a little bit. And again, Dr. Imlay can add. So the reason to get flu vaccines for a number of people are you're more likely to have severe illness. So those over 65, pregnant women, immunocompromised, those people are more likely to get seriously ill than young, healthier people. And so vaccination is of utmost importance for those groups. For pregnant women, it's a little different. One, they're at risk of severe illness, but also we can't vaccinate kids under 6 months of age or less. And so part of vaccinating a pregnant woman is helping to give the baby antibodies to protect them from the flu, because they're at risk of severe illness too.
Dr. Imlay, do you want to comment as it relates to the COVID vaccine?
Sure. So yes, I recommend, as an infectious disease doctor, I recommend influenza vaccine and COVID vaccine for all 3 of those groups. As I think we've talked about on this platform before, when is the right timing, particularly if you're immunocompromised, so not those two other groups, but immunocompromised patients. What is the right time to get the vaccine? Sometimes that can be discussed with your physician, really as a way to answer the question, what is the right timing between my vaccination and my immunocompromising condition or therapy that increases the chance that I'll have a good response to COVID-19 vaccination. However, I would say get it. I mean, I think that's the biggest take home. The other 2 points specifically for the COVID vaccine in immunocompromised patients is that, again, that primary series of COVID-19 vaccination is 3 shots, not 2, for immunocompromised patients, really to improve the primary series immunogenicity. And the other thing for immunocompromised patients is that because vaccination may elicit a lower immune response, we also have additional tools to combat SARS-CoV-2, particularly long-lasting monoclonal antibody called tixagevimab-silgavimab, also called Evusheld, and that's something else to talk to your physician about.
Okay, that was a mouthful. I don't know that I could ever repeat what you just said. So
unfortunately, I mostly just call it Evusheld.
Okay.
For that reason.
And I know, can you tell us a little bit about kids and vaccines? I know you're not a pediatric specialist, but are the COVID vaccines safe for kids? And just give us some very basic general information.
Sure, yes. So I have 2 kids, so I can speak as a mom. Yes, COVID vaccination is safe for kids. We have big data from both mRNA vaccine types, so Pfizer and Moderna, with very good safety outcomes in children. The vaccine schedule is increasingly confusing. Now that these bivalent boosters are authorized in patients who are 12 and up, that does not really address the kids that are between 6 months and 11 years. So when you're trying to navigate who gets what vaccine when, absolutely call the pediatrician, because again, that it is increasingly confusing as there are different recommendations for different age groups, even by type of vaccine. I do want to comment specifically on some safety side effects that have been noted, particularly in young people, which is the risk of myocarditis and pericarditis associated with mRNA vaccination. And again, these are incredibly uncommon uncommon side effects that occur to the extent that they require millions of people to actually note. But that is something that is worth thinking about if you are or have a teenage, particularly male, between the ages of sort of 12 and 25. That has been noted in a few age groups. And I think that's important to mention because it's also important after you get vaccination if you start to notice side effects that you kind of know that this has occurred. So that would be something to talk to your physician. Some things that have been discussed would be things like spacing out doses or other strategies to decrease the risk of those side effects. But even in that age group, I say absolutely get it.
Yeah, I was going to say, I think the other thing to note here is that we've become really good at noticing if one of those side effects is taking effect on someone. So we're good at preventing serious illness. So I want to ask you a brief question. So we're hearing that although you mentioned we still have, was it 500 deaths? Is it a day or a week?
Yeah, give or take.
Okay.
Nationally.
Because of the antivirals and the monoclonal antibodies, we are seeing a decreased risk. So who is a candidate for those therapies if they get COVID?
Great question. Those therapies are specifically designed for high-risk patients and specifically designed to decrease severe outcomes from COVID-19. So we're really talking about, we use these if you're at risk of hospitalization or dying from COVID. Now, all of these therapies were tested kind of in a different time, right? It was a different time when people were not vaccinated and when we had different strains circulating. And few of them have been sort of studied in a really robust fashion during Omicron and in a population that's really with a really high rate of either vaccination or previous SARS-CoV-2 immunity. So in general, the things that make people highest risk are older age, particularly people over 65, and those with a lot of chronic medical conditions. particularly chronic kidney disease, chronic heart disease, diabetes, or immunocompromising conditions, or chronic lung disease. I should add that too. So if you have one or more of those risk factors, these would be things that can prevent severe outcomes. Now, we have not seen any good data to say that they shorten the duration of symptoms, actually. So among people who are low risk, we don't actually see a lot of good data saying that they make your course milder. Those are something we're still waiting on. So I really, in my practice, reserve these for patients that I worry about severe outcomes from COVID with, and particularly Paxlovid, the nirmatrelvir ritonavir, sorry again, or the monoclonal antibodies, which are designed to kind of bind to the spike protein.
And can you clarify, this has come up as a question, is there a difference in risk between type 1 diabetes and type 2? I've heard there is. I don't know if that's true.
I don't know if that's true. I would guess that both of those confer a good bit of risk, but I don't know the differences.
Okay. And Dr. Graves, can you give us a snapshot of what we're seeing in the hospital, what we've been seeing, what we're seeing now, and do you know what's on the horizon? Are we still at capacity? Is it still really critical? Give us an idea of what's been going on.
Yeah, great question. And so I, in the past, have talked a little bit about what's going on in the hospital as a direct effect of COVID-19 and an indirect effect of COVID-19. So I'm going to use that framework again. So the direct effect of COVID-19, the good news is we actually have come down on our hospitalizations over the last several weeks. And so we are now at a point where the number of people in our hospital with COVID-19 is similar to what it was at the end of the spring. So we've come down a bit from this summer wave. That's great. That's the direct effect of COVID-19. The indirect effect of COVID-19 is that in the Mountain West, we've had tremendous population growth. We have a lot of people that didn't get care over the last 2 years. And so we remain a really busy health system. And so as a physician and as an administrator and a leader, I think it's important that we all do everything we can to maintain our health. And that includes getting vaccinated when we're ill, staying home, preventing disease transmission. So less COVID in the hospital, but still very busy, and do what you can to stay healthy because it's just generally a good idea.
Any final thoughts from you, Dr. Graves?
Oh, great question. I think what I would just say is that, yes, COVID is downtrending in Utah, but still important to take measures to protect yourselves against both severe illness from COVID and severe illness from the flu. I agree with Dr. Imlay, we could see more this fall. And so these vaccines are tremendous in keeping people out of the ICU and keep people from dying. And so I would recommend getting both.
Dr. Imlay, I'll give you the final word.
Okay, thank you. Yeah, I think all of this content has been great. I think one thing that we talk about a lot with COVID-19 is the risk of severe outcomes. That's what, the best protection of vaccine is against severe disease like hospitalization or death. The best protection of these antivirals, they're designed to protect against hospitalization or death. And I think we forget to say that people at low risk of disease, this is really disruptive to their lives. It's difficult, you take a break from school, have to take a break from work. There's a lot of reasons, in addition to a personal risk of severe outcomes like hospitalizations, there's a lot of reasons why you don't want to get COVID-19. The other major reason, as we've also talked about before, is the risk of passing it to someone who is vulnerable. And I think even though we think that the risk of severe outcomes is going down associated with some of these new variants of COVID, even though we are now 3 years into the pandemic and a lot of people have been vaccinated, I think it's worth keeping that in mind and still decreasing risk as much as possible from anyone getting COVID-19.
Well, thank you both, Dr. Graves and Dr. Imlay, for being with us today. I don't notice any other questions in the chat, so I think we're going to wrap it up. But if anyone has any follow-up, please contact either me, Sue, or Kylene, and we'll be happy to help you out. Thanks, everybody.